Welcome to this month's webinar that is being brought to you in collaboration with the American Society of the Diagnostic and Interventional Nephrology, American Society of the Diagnostic and International Nephrology. We have been collaborating together this year for a series of webinars. We're very pleased with the participation so far. And I'm Fran Rickenbach. I'm the Executive Director for the National Association of Nephrology Technicians Technologists. Happy National Dialysis Technician Recognition Week. I hope that each of you are experiencing some sort of special recognition from your dialysis unit this week. It is my pleasure to introduce to you Dr. Mukesh Sharma. He has been an interventional nephrologist, and he also serves as clinical associate professor at the University of Nevada, Reno. He's been in private practice for over 13 years, and he has more than, count them, 6,000 procedures performed. He's very active in ASDIN. He's been on the council since 2023. He serves on numerous committees, and he emphasizes education and fellow training. He's been certified in hemodialysis vascular access procedures with ASDIN since 2015. Now, Dr. Sharma is bringing to us his superpower, and his superpower is that he envisions a dialysis access champion in every nephrology group, ensuring that dialysis access receives the attention and recognition it deserves within the broader field of nephrology. We are absolutely delighted to have him speak to us during this very special week. We love dialysis access champions, and given the theme of our week is to empower dialysis excellence, empowering people to be dialysis access champions seems to just go hand in hand. So Dr. Sharma, I'm turning this over to you. After I say to people, Dr. Sharma is willing to entertain questions throughout the meeting. We just ask that you raise your hand in Zoom. If you don't know how to raise your hand in Zoom, make sure that your camera's on and wave your hand, and Dr. Sharma will recognize you. So, Dr. Sharma, over to you.
Thank you, Fran, very much for an elaborate introduction. Yeah. First of all, I would like to congratulate all of you on the National Dialysis Technician Recognition Week. What an honor to be amongst you to talk about dialysis access, which is the lifeline for our patients on dialysis. And you guys are true heroes of the dialysis world and true heroes for our patients, because without the technicians and the technologists, dialysis will not be possible. And it's a life-saving treatment for so many of our patients. So kudos and hats off and congratulations to all of you. So the topic of our discussion is what happens when you send your patients to the access center, what are the procedures that are done, and what are the things you should be looking for pre and post intervention. For my disclosures, I do not have any financial relationship with the industry relevant to the content of this presentation. And these are the objectives and some of the goals I would like to achieve through today's talk. First of all, we will try to see what an access center is. Sometimes in procedure notes and in referral forms, these are mentioned as vascular access center or as acronym that stands as VAC, or an ambulatory surgical center, or an ASC. Then we'll look at what are the procedures performed, what actually happens during these procedures, how can you prepare your patients who have procedures scheduled. And then at the end, we'll also look at benefits of access centers to patients and the dialysis units. And then we'll also go over when to refer your patients to an access center. So starting with what is a vascular access center? So first of all, it's an outpatient procedure center exclusively dedicated to dialysis vascular access. So a majority, actually most of the access centers do not do any other procedures other than take care of the dialysis vascular access. So this is very different from the procedures that are performed in the hospital, which are usually done by an interventional radiologist or vascular surgeons that have many other things to do other than take care of the vascular access. So vascular access being so important for our dialysis patients, these centers are exclusively meant to serve our patient population who is dependent on dialysis. And like I said, there are some acronyms that you may come across, like ASC, which stands for Ambulatory Surgical Center, or an OBL, Office-Based Lab, or EOP, Extension of Practice. These are administrative, from the business standpoint, have different designations, but from your standpoint, there should not be any difference whether it's an ASC or an OBL or EOP. Sometimes, depending on patient's insurance, and if the insurance covers a certain procedure, this may make a difference, but overall, these all are classified as vascular access centers. Each center is equipped with trained staff and supplies that are needed to do procedures on vascular access. And there are three main goals that each vascular access center tries to achieve. One is to ensure continued function of the current dialysis access. Number two is to maximize the longevity of the dialysis access and try to use an AV fistula or an AV graft for as long as possible so that patients do not need repetitive surgeries. And the third and perhaps the most important goal is to keep the patients from going to the ER or hospital. That means if they have any problems with their dialysis access, the vascular access centers can take care of these problems on an outpatient basis and hopefully reduce hospitalizations for our very sick patient population. And some of the access centers may do some non-dialysis access services like working on peripheral arterial disease, varicose veins, etc. But majority of the procedures are exclusively dedicated to the dialysis access. The staff at access center consists of trained physicians. There are many interventional nephrologists who are trained in intervention, such as myself, who are exclusively dedicated to taking care of these patients. And some of the access centers may have interventional radiologists who may do other procedures other than taking care of dialysis access. And a few of the access centers also have vascular surgeons on staff who can actually create fistulas and grafts on an outpatient basis. The difference between interventional nephrologist and interventional radiologist is that an interventional nephrologist will have a greater understanding of the need to do the procedure and the importance, because we take care of our dialysis population. A radiologist may be doing procedures on such patients, but they never see the patients while actual dialysis is being performed in the hospital or outpatient setting. So in my mind, being an interventional nephrologist is an added advantage because we are exposed to the other side of the dialysis access, meaning we face difficulty and challenges of how these dialysis access can pose on an outpatient basis. So we are better geared and prepared to render services to our dialysis population. Then we have trained nurses. Like all dialysis units, each access center has a facility administrator, usually a very experienced RN or who has also experience in administration. Then we have registered nurses who have an experience in the pre-op area, uh, in the operation theater, and the post-op care of the patients. We have trained surgical technicians who are assistants to the interventionists while doing the procedure is performed. And then we have front office scheduling staff, just like we have them in the front office in the dialysis units. So in my mind, when you look at the procedures that are routinely performed at a vascular access center, they can be divided into three types. The first one is to serve the existing or the mature access which is in use. So these procedures are classified under like a repair and maintenance of an existing fistula. Then we do procedures to help a newly created AV fistula mature so that it can be used for dialysis as early as possible. And the third category is to maintenance or procedures related to catheters. So these are a gamut of procedures that we perform, starting with the angiogram, or which is also another terminology is called fistulogram, or if it is a graft, it can be called graftogram. Balloon angioplasty is the most common procedure performed at the access center. Then we also place stents as clinically indicated, and we will go through some clinical cases. And thrombectomy or declot is another procedure that is done when an dialysis access clots. Some of the access centers also do banding or ligation for very large fistulas to decrease the flow. And then to help a new AV fistula mature, or before an AV fistula can be placed, there are few procedures that access center can perform, which is like vein mapping or venograms, Doppler ultrasound. Then for maturation purposes, they can do coil embolization or accessory vein ligation. These are just some of the certain procedures to help a baby AV fistula mature so that it becomes a mature fistula where you guys can be confident in cannulating the AV fistula. For catheters, we do temporary and tunneled catheter placements or exchanges for dysfunctional catheters. Some of the access centers also do PD catheter placements. If a PD catheter is not working well, then we can do catheterograms or readjustment of the PD catheter. And some of the access centers or some of the interventions also do subcutaneous ports for patients who have difficult access on home dialysis. So let's look at what an access center is and what's the daily routine. So since this is a webinar, I would try to give you a tour of our access center so that you have an opportunity to look inside an access center and see how an access center, typical access center is. So this is our front desk where a patient will check in. It's similar to a check-in process at your dialysis unit where the patient comes in and they have a wristband that is put on, and the front staff verifies the patient's name, why the referral was made, and then a nurse comes from the pre-op area to collect the patient and takes them to the pre-procedure nursing area, where the assessment mainly includes the nurse will verify when was the last dialysis done, or if patients had any missed dialysis, what kind of access do they have, and they look at the referral paper to ascertain why the patient was referred to the access center, and then take their vital signs and do a physical exam to see if the patient is stable enough, go over their medication list, and so on and so forth. And once the patient is deemed fit by the nursing staff, stable for the procedure, the physician comes in, does a physical exam on the patient, does a physical exam on the access, and verifies with the patient, sits down with the patient to look at the access and see what are the problems. So sometimes we use a bedside ultrasound, and sometimes before we take the patient to the procedure room, and that helps to visualize where the problem is before we actually do the procedures. And in many cases, in a few amount of cases, we are actually able to mark on the fistula the suggested cannulation sites And in a small number of patients, the patient may not actually need a procedure done if the ultrasound shows that the fistula or the graft does not have any underlying problems. This is a typical procedure room for an access center. The main component here is the C-arm that you can see here. It is basically an advanced X-ray machine that can take X-rays in a motion, like a movie. So this is your operating table where the patient lies down, and the patient usually extends his arm if it is a left side, or if it is a right side, the arm is extended, arm extender is on this side. The C-room comes across, and we put a needle into the graft or the fistula and start injecting contrast. I will show you the pictures in just a little bit. And once the contrast is caught up, because it's radio opaque, the X-ray catches it and the movie shows it, we are able to clearly delineate what the underlying problem is. And if we see any significant stenosis or blockage, we are able to address it through balloon angioplasty. This is another view of the C-arm. This is where the X-ray shoots from, and this is where the screen with the X-ray rays are captured, and they are projected onto the screen. This is our supply stock room where we keep all our supplies like balloons and different type of catheters and stents, etc. And once the patient is done with the procedure, he's brought back to the recovery area where vital signs are monitored after they receive conscious sedation from the procedure. And the patient is usually here for about 45 minutes to an hour, depending on how much sedation they received for the procedure. And this is our documentation room where the physician, once he's done with the procedure, comes and documents so that a report can be sent to the dialysis units and to you guys so that you can go over what was done on the access and if we have any recommendations on how to use the access or when to use the access. So a very important question from your standpoint is how to prepare my patient scheduled for a procedure at the access center. First of all, I want to really impress on the fact to alleviate anxiety for newer patients who are coming to the access center for the first time. You can stress on the patient that this is an outpatient procedure. It is not a surgery. There will not be any cutting involved, no sutures for almost 90 to 95% of the patients when they go in for a fistulogram or have their access checked out. So this is for some patients who haven't been to an access center, provokes a lot of anxiety that they are going for a surgery or a procedure on their access. But most of our interventions are through a very small needle or a hole, and most of my patients goes out without any suture placed. And they are in the access center for a couple of hours, including the pre-op assessment, the intra-op procedure, which can last from anywhere from 15 minutes to 30 minutes, depending on what kind of procedure it is, and another 45 minutes to an hour in the post-op area, and they are in and out of the access center within a couple of hours. So if you have a patient that has a thrombosed access, they do not need to go to the ER or hospital. We can get the thrombectomy done the same day, and most of the patients are able to resume dialysis either the same day or the next day without the need to sit in the hospital for 2-3 days. And we absolutely avoid placing catheters in such patients. So that is a very important thing, alleviate anxiety for patients. That an ambulatory surgical center or dialysis access center is exclusively meant for our dialysis patients, and these are the only procedures we provide expertise in. Number 2 point is dialysis compliance prior to the scheduled procedure. So unless it's an emergent procedure like a thrombectomy or catheter not working and they had to miss dialysis, we do recommend that the patients be compliant with their outpatient dialysis, because when we provide conscious sedation, we do not want the patient potassium to be high, because it's going to cause different kind of arrhythmias and heart issues. And if they are volume overloaded, then they can have problems lying down supine on the operation table. So that's why dialysis um, before a day or 2 days before the procedure is recommended. NPO for 6 to 8 hours and meds with sips of water are okay. This is mainly because most of the patients will need sedation medicines. So although they are not completely knocked out, we do not do any general anesthesia. It's a conscious sedation with Versed and fentanyl. The type of medicines you get when you go for outpatient colonoscopy or endoscopy. The patient is usually awake throughout the procedure or in a very light sleep for 15 to 20 minutes. Most patients don't feel any pain, but they are still awake to the point that if we gently tap them, they come back or arouse from sleep. So we recommend that they do not eat anything just to prevent any aspiration risk while they are having the sedation. And then one most important thing is to have a responsible driver come along with the patient, either a family member or a friend. And if none of them are available, that the patient has means to call in for a taxi or an Uber, and Access Center can help. And this is mainly because we don't want the patient to drive themselves after they receive those sedation medicines. And then you can also ask the patient if they have any allergy to IV contrast or sedation meds. Usually the Access Center staff goes over all these questions with the patient when they are scheduling the patient. But this is just to give you some idea how to prepare your patient. If they have any allergy to contrast or sedation meds in the past, how severe was that allergic reaction? And if it was a true allergy, which we ask and verify with the patient in the pre-op, we give them prednisone and Benadryl IV during the procedure. And for some patients who need more procedures or who have known allergy, we also prescribe oral prednisone and Benadryl a day before coming to the Access Center. And then just to mentally prepare the patient, ask the patient that they will be at the Access Center for 2 to 3 hours. Medications is an important question, mostly related from the nursing standpoint, that if they are on insulin and because they are NPO for 6 to 8 hours, they can skip the short-acting insulin, but we recommend them to take half dose of long-acting insulin. And if they are on blood thinners, whether they need to be held or not, we'll go over the anticoagulation in the next couple of slides. So another important question is when to refer my patient to an Access Center. Of course, when you're having any difficulty accessing the AV fistula or a graft, that is the most common reason for referral to the Access Center. If they have any frequent infiltrations, mostly with newer fistulas or baby fistulas, and if you have frequent alarms because of the high venous or arterial pressures, that may be an indication of underlying stenosis in the fistulas, as we will see when we look at the clinical cases. And if there is any abnormal physical exam of the access, I'm sure you guys look, feel, and hear all the fistulas and grafts before you put the needles in your patients. So, and because you see the patients more than the nephrologists or rounding providers, you are our eyes and ears. And I always appreciate my techs and tell them you are my eyes and ears for the dialysis access of my patients, because you get to see them more often, 3 to 4 times a week. And then you are more aware of how their fistulas have looked over the months and years. And if there is anything abnormal and you think this is very different and Mr. Smith's fistula never used to look like that or never used to feel, or an abnormal bruise is audible, then you can, after discussion with your rounding provider, refer that patient, because that may be an indication of underlying stenosis or problem with the access. And of course, if the patient is catheter dependent and the catheter is not working and you have reversed the lines, and even with TPA dwells, the catheter continues to be a problem, of course, the catheter may need to be changed. And if the catheter has been displaced or you see an exposed cuff, that is an increased risk of infection or the catheter falling off, that catheter, of course, needs to be changed. And needless to say, if the graft is not running, it is clotted off, yes, that patient needs to be referred for an thrombectomy as early as possible. For patients who are not yet on dialysis, you probably won't be seeing them, but yes, we do vein mappings and new AV access placements at some of the access centers. And of course, if the patient on dialysis is having steal symptoms, we can evaluate them for steal symptoms. What should I do post-intervention after a patient had a procedure done? What are the things? The first thing is when the patient comes after a procedure the next day or day after for their dialysis is to see if the access is usable. And then you will look at the inspection and do a physical exam, as I'm sure all of you do. Look at the access and see if there is any difference. Feel for it, feel the palpation, palpate the access, and feel for the thrill, and then hear with the stethoscope to see if you see any difference. Are there any markings or suggestions for cannulations? I usually make a point if the patient has been referred for difficulty cannulation, I mark with a blue pen with a skin marker, and then we put a transparent taping on it for my technicians and technologists to see what are my suggested sites for cannulations, and it makes their lives and patients' life a lot easier. Any sutures, if there are any sutures, most of them can be removed in 1 to 2 days unless they are otherwise specified. And like I said, 80 to 90% of my patients goes out without any sutures, but that can change and vary depending on which access center is closer to you and who is doing the procedures. So other thing to monitor is any complications or adverse events that happen during the procedure. Usually the nursing staff will take care of this thing. And then if the procedure notes are available, were there any special instructions given to the dialysis staff, to the technicians and nurses about when to start using the AV fistula or which areas to avoid cannulating and things like that. Any questions so far?
There is one question. Other than reversing the lines, what other tips can you provide for troubleshooting a difficult access?
So yes, that's a very good question about the catheter. Usually, I tend to tell my dialysis staff to use TPA and let it dwell at least for an hour before trying to use the catheter again. Most of the problem is from the clot that is sitting at the tip of the catheter. But I will show you the pictures in just a little bit second where TPAs or any kind of heparin or reversing the lines is not going to make a difference because of the faulty placement of the catheter. So just hold on to your thoughts and we'll go over this again. So this is just about anticoagulants, and I think I covered it in. We don't need to spend too much time on this. Every access center have their own protocol. Usually what I ask my patients is not to hold their Plavix or aspirin because most of the procedures at the access centers are very low risk for bleeding. But when they are on warfarin, Eliquis or Xarelto, these are the longer acting blood thinners. Every access center have their own methodology, whether to hold or how long to hold for the procedures. And this is a slide I just put in, and you'll be able to access this later on if you want to look at whether you are sending the patient for a catheter or for a banding or for a normal fistulogram. And most of my patients don't have to hold any type of anticoagulation for a simple fistulogram or angioplasty because the risk of bleeding is relatively very low as compared to open surgeries. So let's go over clinical cases, and hopefully this will answer some of your questions that you may have. So just to go over an anatomy of an axis, this is very familiar. Forearm radiocephalic AV fistula in the left arm. And every axis anatomically can be divided into three areas. First is the inflow, where the axis, the radial artery is connected to the cephalic vein over here, and the blood coming from the heart and travels directly to the vein, and over a period of time, the vein matures. So this is called the inflow. This is your favorite zone called the body of the AV fistula, or the cannulation zone. This is where you will cannulate the AV fistula, and this has a really nice long distance mature cephalic vein, kind of ripe and pulp and ready for cannulations. And the third part of the fistula is the outflow. So all the distance after the body, all the veins carry blood back to the heart, and the distance from the body of the AV fistula and to the heart constitutes the outflow. So, and I'm showing you this because there may be different kind of stenosis or problems depending on what part of the fistula we have. So let's go over the first case. This patient was referred for increased collateral veins, as you can see in the chest, in the shoulder area. The axis is right here, right upper arm, brachio basilic AV fistula. And patient was also having increased venous pressures and prolonged bleeding on dialysis. So this is the fistulogram that shows complete stenosis of the central vein. Just to orient you, this is the circle area is the part of the body that we are looking at. This is the right upper arm AV fistula that ultimately drains into the central veins. And this circle is basically showing you the subclavian vein. This is the internal jugular vein, and this part of the vein is completely occluded. And that is the reason, because the fistula is pumping all the blood, and the blood cannot go back to the heart, which is here. The body tries to form different collateral channels in order to drain the AV fistula. Another picture to show that this is where most of the dialysis catheters goes. This is your internal jugular vein. This is the brachiocephalic or the innominate vein, the superior vena cava, and here is the heart. So in this picture over here, you are seeing this part of the vein, but because of the previous catheter in this patient, the right brachiocephalic vein is completely occluded. That's why you don't see any contrast going down to the heart. So what did we do for this patient? We were able to pass a wire across this area, and then we were able to open a balloon. This is a large balloon. We usually start with a smaller balloon and gradually increase the size. And you can see the kink of the balloon here that signifies significant stenosis. Here, the balloon is completely open, and this is what you see after the angioplasty. So you can see the contrast flowing back into the heart, and now the reflux into the head is, or the neck veins is completely not visualized. That means the flow has been restored back, and this will help with the prolonged bleeding or the increased venous pressures that cause frequent alarms on dialysis. Case number 2, the patient was referred for difficulty cannulations and frequent infiltrations. This is the cannulation zone. This is again left upper arm AV fistula that showed severe up to 95% stenosis. And you can imagine how difficult it would be for anyone to place a needle. And here, because of this very significant stenosis, there was an infiltration and blood is seen to be collecting here. So we were able to treat it with angioplasty as well. After passing a wire, we opened up this area with balloon angioplasty, and you can see the clear difference between the pre and the post pictures. This is another case of cephalic arch stenosis. And as you can see, just to orient you again, we are looking at the shoulder and the chest area. This is the vein that is draining the fistula back into the subclavian vein. Here is the collarbone, and you see the ribs. And as you can see, these metallic parts is actually a stent that was previously put in because of perhaps recurrent stenosis or blockages in the vein. But the stenosis has progressed, and now, although the stent is open, the vein beyond the stent is completely cut off. So just another picture to show the problem. We were able to pass a wire, and as you can see, the kink in the balloon, this is where the significant stenosis is. And we kept on trying, but the balloon would not fully efface. So I was able to cross the wire in another direction in an attempt to open the stenosis. But the results were not very promising even after doing this. So sometimes you have to think out of the box. I was able to pass a wire from another vein across this area and open the balloons over there. And this resulted in actually resolution of the problem. Now you can see the complete stenosis is resolved into almost 20%, 10 to 20% residual, but at least helped with the problem, and we were able to use the AV fistula. And this is just to give an example that although we are in private practice, such cases are often reported. And I presented this case at one of the ASDIN conferences, and it was selected because of the unusual presentation and the unusual approach that I took to solve this case. The next case is again for prolonged bleeding, high venous pressures, and a very pulsatile AV fistula. And after performing the fistulogram, you can see the tight stenosis. And this is the outflow area again. This is your cannulation zone. And you can imagine if there is such tight stenosis, this part of the AV fistula becomes aneurysmal. And because it has difficulty for the blood flow to go across this stenosed or tiny area, the venous pressures will be very high. And this is the upper part of this AV fistula. Patient had problems and already had a stent in the upper part, but that was completely open. This is the central part of the AV fistula. We do a complete checkup up to the heart, make sure there is no other problems. And once we resolve that our other part of the AV fistula looks okay, we start opening the balloon. This is a 9mm balloon. Here, the balloon is fully open. And this is case highlights one of the problems with the angioplasty that can happen, that although the balloon required high pressure to open, but as you can see, the contrast leaking out. And this is because the vein was too weak to undergo angioplasty and kind of ruptured. But we do have, we can tackle these situations without having the patient to undergo open repair or surgery by placing a covered stent. So I was able to place a stent across this area. And this is a careful placement because I was careful not to place the stent in the cannulation zone. So the stent served two purposes. One is it sealed off the bleeding in this area. And the number two, it took care of the underlying stenosis. The fistula became less hyperpulsatile, and we were able to maintain the patency of the fistula. This is another case where a female was referred for swelling in the access arm. As you can see, this is a forearm AV fistula. She had dialysis the day before and had prolonged bleeding, high venous pressures, along with the swollen left arm. When we performed a fistulogram, she had a history of known cephalic arch, actually brachiocephalic central vein stenosis, and you can already see two stents that are completely blocked, as you see no flow of contrast into this across the stents. We were able to pass a wire across this area and do balloon angioplasty. And because she had a long history of stenosis, and usually once the stents develop in-stent stenosis, it's just a matter of time before angioplasty alone will not help and stenosis will recur. So I ended up placing another stent to maintain the patency and prolong the use of the current AV fistula. Because once you're not able to pass a wire or perform an angioplasty, most likely the fistula will shut down and she will need to have another access. So this is just a measure. Like I showed you, one of the goals is to prolong the use of current AV fistulas for as long as possible so that we can preserve patient's vein and she can avoid the need for another surgery. So coming to the catheter problems, this is a right side chest permacath, and this is how you guys look at it for most of the patients. And it's often not easy to diagnose problems of the catheter just by our naked eye exam for reasons I will just show you in a second. So this is a normal looking catheter placement. You see a nice curve here, and the catheter tip needs to be in the right atrium, or at least at the SVC right atrial junction. So same cases, just for your comparison, I'll show you the first case. A patient was referred for catheter not working, and despite heparin dwells and TPA dwells, the catheter was not working. And when we took the picture, you can see there's a sharp kink here at the neck, and this is over here. And through physical exam or external eye exam, you won't be able to diagnose the problem. So this catheter is not going to work regardless of how many times you switch the lines or how much TPA you dwell because of the sharp kink. And as you can see, the catheter tip has been pulled up into the SVC, hence explaining dysfunctional catheter. So this catheter needs to be replaced. This is an example of another catheter. It may look the same from outside, but you can see the catheter tip has been pulled up all the way into the neck. And no matter how many times you change lines or do TPA dwells, this catheter is not going to work. This needs to come out and a new catheter needs to be placed. Another example of the catheter pull-in, it has been pulled back into the neck and there is no way this catheter is going to work. So we'll need a catheter exchange. And the only way to diagnose such problems is by getting a chest X-ray or under the fluoroscopy. You see actually where the catheter tip is. So a simple chest X-ray helps a lot to diagnose the underlying problem. Another example of a catheter, as you can see, this is a very long catheter. The exit site, unfortunately, sometimes done by surgeons, is very low in the chest. The catheter exit site should be very close to the clavicle, and he used a very long catheter, but unfortunately, you can see the catheter tip is way high in the neck, and this catheter is not going to work. Another important reason why catheters stop working, especially if they have been in place for more than few weeks, is because of the formation of fibrin sheath around the catheter. And here you can see a thin layer of fibrin material that is blocking off the holes and the catheter tip. So regardless of heparin or TPA, the TPA cannot dissolve the fibrin sheath. So although the catheter position may look okay, the catheter may not have any kink, the catheter tip may be in the right place, but because of this fibrin sheath, this catheter needs to come out and a new catheter needs to be placed. And this is another example of a fibrin sheath causing problems. And usually the fibrin sheath extends from the tip of the catheter all the way up to the cuff. Steele syndrome is another thing that we all need to be aware of. And unfortunately, I hope you never get to see these kind of late presentations, but unfortunately, it is not uncommon for us to see when patients are referred too late. This is two different patients who were referred for unhealing, non-healing wounds. But unfortunately, you can see this is pure ischemic gangrene because of poor blood supply because of the AV fistulas. And mostly diabetic patients, female patients, patients with low blood pressure, they are at very high risk of developing Steele syndrome. These are two small videos. Let me see if I can play this. So this is the left brachial cesarean fistula, about 2 years old, and the patient came in with complaints of numbness and pain in the hand, which worsens on dialysis. The three surgical scars over here. This is the main fistula. Are you guys able to hear it?
Yes, we are. Can you turn it up a bit?
Oh, sorry. So I'm trying to show you a patient who was referred for possible Steele, and I'm trying to show you how a simple oximeter at the dialysis unit can help you diagnose whether this patient has significant Steele or not. So with the fistula, this is just in the pre-op area. I checked his pulse ox, and it was around 86 to 87% with the fistula open. So I'll fast forward to save time. What happens here is I go and then occlude his AV fistula in order to improve the blood flow into the hand. And you can start seeing within few seconds or minutes, the oxygenation in the hands will improve, meaning the blood supply has been restored. So it was 86, 87%. Now it's 89%. This is unfortunately upside down. But you will see slowly it goes up to 90 to 93%, meaning that the fistula in the upper arm is stealing significant flow. And once I ligate the fistula or occlude the fistula, it improves the blood supply to the hand. So this is early detection of Steele, and this is a test you can easily do at the dialysis unit if you have a concern of patient complaining of pain in the hand or color changes in the hand, so that you can save patients digits or save patients from going or to the ischemia or gangrene side. This is another video I made for a simple test that all of you can do at your dialysis unit. This is called an arm elevation and collapse test. So this is a very old 12-year-old fistula, and you can see it's aneurysmal. As I raise the arm, the fistula collapses. What it means is that regardless of the aneurysms, if the fistula is collapsing, there is no underlying stenosis either in the body or the rest of the AV fistula. So just a simple test of raising the arm. If you see the fistula collapsing, even partially or completely, it completely rules out stenosis and the rest of the AV fistula. So you can do this within like 30 seconds on all your patients, and they don't even need a procedure to make sure that there is no underlying stenosis causing the aneurysms. These are maturation exercises that you can suggest for patients who are catheter dependent and who have new AV access. Ball squeeze, pin clothes pin exercise for elderly patients who cannot squeeze a ball. Then for younger patients who are healthier, you can use hand grip exercises or even lightweight dumbbells. And all these exercises are a direct way to improve the blood flow into the newly anastomosed vein into the artery. The more the blood flows into the vein, the faster the vein will mature, and the faster you can start using that AV fistula. So coming to the benefits of access center. So I'm going to discuss first the benefits to the patients. So first of all, it's very convenient because it's an outpatient procedures can happen in the access centers. The patients do not need to go to the ER or hospitals if they have an urgency or any problems with their access. We do not give general anesthesia. We do all procedures under conscious sedation. So patients many times in the hospital are not cleared for surgery by anesthesia, and they spend many days in the hospital for for the procedures to get done. Whereas in the access center, even high risk patients can get these procedures because these are lower risk procedures for us, and we are comfortable in managing these patients outpatient. And then, of course, psychological reassurance to alleviate the anxiety of the patient that it's not a surgery. We are not going to cut their fistula or leave any surgical scar. Most of the patients leave out without any suture, and they can return back to their home or work or have same-day dialysis after the procedure is done. Another convenience factor is that if they establish care with an access center, they get to see the similar faces, the same physicians who are employed in the access center, the same nurses and the staff, just like they become familiar with you guys, seeing your faces and your friendly faces and your friendly hands 3 times a week. They become familiar with us as well and are very comfortable in coming back to us to take care of the dialysis access. And then another important thing is you get the ability to test the success of the procedure. If fistula has clotted and patient undergoes a declot, patient can usually go back to the dialysis unit the same day if it is done earlier in the day or the next day to test if the procedure was successful or not. And then, of course, because it's an outpatient procedure, it is much, much less expensive overall to the patient and to the insurance and to all the taxpayers, and saves a lot of money for everyone if the procedure is done outside the hospital on an outpatient basis. Benefits to the dialysis units. An access center is a major asset to improve quality metrics by reducing the catheter rates, by helping mature AV fistulas faster, sooner, and even avoiding the catheters in cases of thrombectomies where thrombectomy can be done in the same day and the patient does not need to have a catheter placed. Many times in hospitals, because the surgeons and IR is so busy, most of the patients end up getting a temporary catheter put in until they can go to the OR or have anesthesia clear them for thrombectomy. And then the catheter is taken out. Patients spend 3 days in the hospital just for thrombectomy versus coming to the access center, getting the procedure done the same day and getting dialysis either the same day or the next day. So that way you improve the AV fistula rates in the dialysis unit, reduce the catheter rates, and then prevent and treat thrombectomy as soon as possible. Then because you are able to keep the patients out of the hospital, you also reduce the missed dialysis treatments for such patients. It's a pretty quick scheduling for ambulatory surgical centers or access centers because this is what we do day in and day out. And most of the times, this is an emergency for us to save patients' dialysis access, just like it's an emergency for you guys because they cannot do their dialysis without a dialysis access. And of course, it increases patient satisfaction and feedback because they avoid costly hospitalizations. No one wants to be in the hospital if they can avoid it. So with that, I want to keep some time for any questions if you guys have any. I wish you a very wonderful National Dialysis Technician Week. You all are heroes, and we cannot take care of our patients without you guys. And I also want to extend an invitation for you guys to attend our national conference at ASDIN. We are going to have it in Orlando in February next year, and we have dedicated sessions for technicians, which runs for almost a complete day, totally dedicated to the technicians. So with that, I will stop and see if you guys have any questions or any concerns or anything that comes to your mind that I can help address.
We did have one question. Does the pulse oximeter, have to be on the
Oximeter.
pinky finger? Oximeter. I know how to
No,
say
it does not have to be on pinky finger. It can be on any of the fingers. From a dialysis access standpoint, it can be on any of the fingers. When patient usually is referred for us to steal, we actually test pulse oximeter on all the fingers of the access arm, and we do oximetry on all the fingers of the other arm so that we can make a comparison. What is the difference between those two fingers? So, but to answer your question, it does not necessarily need to be on pinky finger. It can be on any finger.
Thank you. Those were the questions in the chat. Does anybody else have any other questions? You're welcome to unmute and ask.
Yes. I'm actually not able to see any hands because I'm not, let me try to see.
That's
Change my
okay.
hand.
There aren't any hands. You've given us a lot of information. I just want to remind people before you log off, if you would like to get a contact hour for this webinar, please, if you were logged in on time, go back through the chat and you will see the link that I put to the form that you need to complete. We'll send you your contact hour within 1 week. If you want to recommend this webinar to your colleagues, it will be available in our learning library free to NANT full members. And so you'll be able to, if your members are, if your friends are full members of NANT, it's only costs $25 and you get access to more than 20 webinars. So that boils down to $1 per contact hour. And we'll be able, so Bintu, you need to check back through your chat to get the to get the link to the form. Dr. Sharma, thank you so very much. This was a fascinating presentation. I learned a lot. Enrique Diaz also says that it was very well presented. So
Thank you very much for this opportunity, and it was amazing. I had a wonderful time to interact with you as well, and always nice uh, to discuss these things with the daily heroes for our dialysis patients.
well, thank you. And our theme for National Dialysis Technician Recognition Week this year is Empowering Dialysis Excellence. And the next step in dialysis, empowering dialysis excellence is our DTX43, which is our conference that is going to be held March 10th through the 13th in Planet Hollywood in Las Vegas. And we're opening registration for that on Tuesday. So thank you again. I'm going to